And now start down. Did you read respiratory diseases? Let me to explain today is COPD because COPD I didn't explain last time, okay? Therefore, let me to finish with COPD, and in next part I will explain the gastroenterological diseases okay? So I guess you understand this COPD, okay? Sorry, I guess you understand asthma, okay? You have any questions regarding asthma? Huh? You have any questions regarding asthma? Did you understand everything here?
Yes,
Huh?
yes, everything.
Can I proceed now? Can I proceed now with COPD? So, what is the COPD? COPD is chronic obstructive pulmonary disease. This is related with the airflow limitation, which is not fully reversible. Okay, here we have the obstruction of the airways, which is not fully reversible, and usually this progresses. And finally, we have the also damages and fixed obstruction of the airways. Okay, usually the COPD is related with the of inflammation, and inflammation may lead to obstruction of the bronchi. So how do you think why the inflammation occurs? Due to is this occurs usually due to exposure to different damaging factors, like and main risk factor for COPD is smoking. You know the smoke is considered the main risk factor for lung disease. Okay, therefore the obstruction usually in COPD is found in mostly smokers and mostly it's related with smoking. Okay, in order to classify the COPD, we have the two types of diseases. Type A includes emphysema. Type B includes the chronic bronchitis. So now what is emphysema? Emphysema is destruction of the alveoli and formation of the bulla. You see, this bulla, it is usually, they are filled with the air. So emphysema usually, normally alveoli should have such type of structure, yes, like a vesicles, okay? But when we have the emphysema, so we have the destruction of alveoli and formation of bullae. And these bullae are filled with the air, okay? This is usually emphysema. Clear for you? So emphysema may be related with congenital pathology, and here we have the congenital deficiency of alpha antitrypsin, which may lead to destruction of alveoli and bullae formation, okay? Clear for you? Do you understand? Likewise, the chronic bronchitis, this one related with the obstruction of the bronchi due to inflammation. And here main risk factors are inhaled pollutions, especially the cigarette smoke. As the patient permanently inhales the smoke, it may lead to inflammation into the bronchial tree, and finally it may lead to obstructive disease. Okay? Here we can see the pathogenesis of the diseases. As I told you, emphysema related with the deficiency of alpha antitrypsin. Likewise, chronic bronchitis is usually related with tobacco exposure or exposure to other pollutants. Like usually, which type of pollutants are we inhaling every day? How do you think? Huh? What is your option? Which type of pollutants we are inhaling every day? Do you know? What is your consideration regarding this topic? Hmm? Guys, I'm asking questions. Which type of air pollution do we know? Huh? You are not listening.
What is the question? Your question isn't clear at all.
Which type of air pollution do we know? Which type of air pollution do we know?
Which type of what?
Air pollutions. You know what is pollution? Gases, gases which can make damage to land. The type of pollution do we know? What is your idea? Huh? Like cars, yes, when cars are driving, they are using also the barrel, yes, they are using also they are releasing the air pollutions, yes, petrol. They are using the petrol in order to drive the car, yes. And while car is moving to the street, it also releases air pollutions. These pollutions are inhaled by us. Every one of us going outside and we are inhaling this air, yes. Therefore, this is
Yes.
usually dirty air, yes. It's not a clean air. Therefore, it may lead to chronic inflammation of the bronchial tree, and finally, it may lead to damage of the bronchial tree, and finally, it may lead to the COPD. Do you understand? Clear?
Yes, yes.
Okay? Or in a person, someone works in a special factory. This factory produces a type of chemical. These chemicals usually are inhaled by the patient and may also lead to damage of the bronchi. And finally, it may lead to also obstructive disease. Okay? Clear for you. So, how we should diagnose this? On the one hand, we have to do spirometry. On the other hand, we have to do the imaging test. For example, here, this is the CT scan of lung emphysema. And you can say, as I told you, in lung emphysema, we have the bullae formation. Yes, bullae are usually large vesicles which are filled with the air, like this. Okay. And on the CT scan, it looks like so. You see the large area. You see, indicates the bullae formation. Okay. Clear? You hearing me? Huh? Did you understand what is the bullseye? Huh? Guys, do you understand what is the bullseye? Guys,
Yes, doctor, can you repeat the question, please?
what is the bullseye? Did you understand it? What is it? Can you tell me it now? I explained already. What is the bullseye? Huh? Please tell me. I explained you. What is the bullseye? Huh?
Doctor, can you please repeat?
Yeah. Sorry, what?
Can you please repeat what I'm not
What is
understanding.
the bullseye? I explained you. What is the bullseye? Can you tell me what is the bullseye now?
Buwari?
Bully.
Ah,
Bullseye. What is emphysema? Huh? What is emphysema? Can you tell me now?
bulimia or bulimia, do you mean?
Bullseye, emphysema. I'm talking about bulimia, about the lung emphysema, about bullseye formation. What is it? What is it? Huh? Can you tell me what is it?
For me, I don't know it.
I just explained you. What is understand what is emphysema? What is emphysema? Huh?
Emphysema, yes, I know what is emphysema.
What is emphysema? I just explained. Oh, I explained. Did you listen to me? What was emphysema?
Emphysema is a lung condition that you can't breathe well anymore.
No, I did not tell such type of six. I did not tell you. What did I tell you? This type of six I was never telling. This type of symptoms. Sorry. What did I tell you regarding the emphysema? I just explained it to you, okay? What did I tell you? Can you repeat it?
Okay.
Because I explained what is the emphysema. Detailing. Now I am waiting your answer. What is the emphysema? Can you tell me it? Such type of questions will come in your midterm, okay? And you should answer it. What is the emphysema? Who will tell me? Guys, if you are not listening, I will stop now and I will go my because I have to go now clinic. If you are not listening to me, it's bad. I will go outside. I will speak a second. I will go to the clinic. Okay? If you would have listened me, I will go to the clinic, okay?
Doctor, can I tell you
Oh,
please what is the problem? That
yes.
we are not understanding the words very well. I don't know if it's because of the Wi-Fi and we are in quarantine here in Georgia. The Wi-Fi is
Ah,
terrible, so we are not understanding very well the words that you are saying.
Yes, doctor.
what is I just said? What is emphysema? I explained it to you. What I told you. Do you remember it?
Doctor,
As I
can you please put
I
it?
told you it.
Maybe we can understand more.
So just listen to me, okay? Emphysema. It is a usual distraction of the alveoli and formation of bullae. Do you understand this one?
yeah,
Normally, alveoli should be like this. Look here, okay? And listen to me. Normally, alveoli should be like this. It's but when we have the destruction of alveoli, we have the formation of the bullae. This is a big vesicles which are filled with the air, okay? And usually this is related with the alpha antitrypsin deficiency. Therefore, emphysema is genetical condition. People who have the deficiency of alpha antitrypsin, they do usually have emphysema. Do you understand it now?
yeah.
Clear?
I told you that you have difficulty in breathing. I told you,
No,
but maybe you did.
I didn't tell, no. I didn't tell you it's difficult of the business. I didn't tell you it's bad. I am not telling that. Maybe it's not. I did not explain, tell you such type of things. Difficulty is a basic. I am not telling in this presentation anywhere. I'm talking about the
Okay.
COPD. This is another condition.
Okay,
Okay,
doctor.
this is the obstructive disease of the lungs. Okay, this is the obstructive
Yeah.
disease. And also, type A is emphysema. So
Yeah.
COPD involves two main diseases. Is emphysema is a chronic bronchitis. Okay,
Yeah.
emphysema is the infection of the alveoli, this formation of bullae. Okay, Uh, likewise, chronic bronchitis is usually obstruction of the bronchi due to exposure of fumes. For example, cigarette smoking, it's a fume, yes? Due to chronic exposure to different pollutions, it may lead to chronic bronchitis. Do you understand? And here, main symptom is coughing. It's not difficulty of breathing here. Main symptom in chronic bronchitis is coughing. Do you understand? Clear?
Yes.
In emphysema, if it was end stage of emphysema, they may have difficulty of breathing. But initially, they do not experience difficulty of breathing, okay? Clear?
Yeah. Yeah.
Therefore, I did not tell you such type of things because it is not certain, okay? So, how
Okay.
we should diagnose the emphysema? I told you we have to do the CT scan of the chest and see whether there are some bullae. You see here we have the bullae. This is for the bullae formation, okay? Clear?
Yes.
And this is definition of the chronic bronchitis. We have to have the persistent productive cough for at least 3 months in the last 2 years, the last two consecutive years, in order to state there is a chronic bronchitis. You see? So here we have to patient should have coughing with the production of the pseudo at least 3 months, at least three consecutive years, at least two consecutive years in order to state there is a chronic bronchitis. And main exposure, here we have cigarette smoking, industrial gases, motor and vehicle fumes and so on, okay? Motor vehicle pollutants and so on. These areas may lead to damage of the bronchial tree and may lead to also chronic bronchitis as well. Do you understand now? Clear?
Yes.
Okay. So anyway, and here we can see the risk factors of COPD, cigarette smoking mainly, occupation exposures. For example, if person usually is working in factory, and in factory we have the exposure of the different gases. These gases are inhaled by the person, and it may lead to damage of the bronchial tree. And finally, we will have the COPD here. Okay, clear? So, as well as here, we may have also some genes or infection or socioeconomic problems, which may also considered as a risk factors for COPD. Okay, clear for you.
Yes.
So now, how we should do the diagnosis of COPD? Usually you have to do spirometry in order to assess the lung volume. Last lecture, I explained you what is this spirometry. Do you remember this graph? Do you remember this? What is this? I explained you last lecture. What is this?
Doctor, I'm really sorry, but last lecture I couldn't watch it because I was coming to Georgia, so
Ah,
I don't know.
this
Okay.
is but who remembers it?
What?
Doctor, we are only two, me and Reem, and we already came to Georgia. We were on the plane.
Ah, same date. Spirometry, I will show you. Now, do you want me to show
Yeah,
you what is spirometry?
we couldn't
Yeah, yeah,
attend
please.
the lecture.
I will show the video, okay, in order to better understand it, okay? Now you are in quarantine. Hmm? You are in quarantine now.
Yes, we
You
are in
said
the hotel right now.
which hotel?
Iberia and
Of how well your lungs are working. So, in which hotel?
Iberia and Tbilisi.
Okay, now watch the video, okay?
Yeah, okay.
Spirometry is a test of how well your lungs are working by measuring how fast and how much air you can breathe in and out. Normally, as you breathe in or inhale, air moves freely through your trachea or windpipe, then through large tubes called bronchi, smaller tubes called bronchioles, and finally into tiny sacs called alveoli. Small blood vessels, called capillaries, surround your alveoli. Oxygen from the air you breathe passes into your capillaries. Then carbon dioxide from your body passes out of your capillaries into an alveolus. You get rid of the carbon dioxide when you breathe out or exhale. Diseases such as asthma, bronchitis, and pulmonary fibrosis narrow your bronchioles, reducing the amount of air going into your lungs. And diseases such as lung cancer and emphysema damage your alveoli, reducing the amount of oxygen in your blood. These diseases can make it hard for you to breathe. Your doctor may recommend a spirometry test to identify a disease in your lungs, check the severity of your existing lung disease, or to determine if the medications you take are helping. During the test, your caregiver will use a device called a spirometer. A spirometer is a machine that measures the air you breathe out. Before you take the spirometry test, you will sit in a comfortable chair with your feet flat on the floor. If you have dentures, you may be asked to remove them. For best results, you will be advised to follow your caregiver's instructions exactly. To start, you will raise your head and chin so that you can breathe easily. Next, you will place a clip on your nose to prevent air from coming out of your nostrils. Then you'll take a deep breath, filling your lungs completely with air, and hold it. You will place the spirometer's mouthpiece between your teeth and tightly seal your lips around it. Finally, you will blast the air out of your lungs as hard and as fast as you can, continuing to breathe out until your caregiver tells you to stop. If you are an adult, you will blow for at least 6 seconds. Children 10 years old and under will blow for 3 seconds. You will need to perform the spirometry test correctly 3 times to get accurate results.
You understand, guys? By the spirometry, we can assess the lungs, how much air is released during expiration, and usually in COPD we have the limited expiration. Therefore, in COPD, here we have the decreased expiratory flow. Okay. So, are you listening to me, guys?
Yes, yes, of course.
Yes,
Yes, right now we
spirometry because it decreases respiratory flow. And also by the spirometry, we can assess the ratio of respiratory volume to forced vital capacity. Okay? And this ratio should be decreased below 1 This indicates the airway are obstructed. Therefore, mainly, if we have the COPD, we have to have the decreased ratio as well as decreased forced expiratory volume. Okay? Why? Because usually COPD reflects respiration. So in previous colleagues, I showed you the graph, okay? Now see, this is the emphysema. You see the parameter for emphysema and they look like this. You have the decreased expiratory flow. This is expiration, this is inspiration. Yes? Usually you should have the decreased expiratory volume here. So in COPD, usually because the decreased expiratory volume, therefore we have the ratio of forced expiratory volume over forced vital capacity will be decreased. Okay? Clear? These patients usually have a barrel shaped chest. This is normal shaped chest, this is barrel shaped chest. Okay? Usually, and they have also the movement of the chest wall. Okay? And usually they have the decreased forced expiratory volume. Okay? This is chronic obstruction of bronchus. Okay? Clear for you.
Yes.
Okay?
Yes.
Now, and on the X-ray, if you do the X-ray, you will see such type of images. Here we have the much due to impaired expiration. Here we have problem with expiration, therefore the much will be accumulated with the alveoli, and therefore to lead give you darker images on the X-ray. You understand? Yeah.
Yes.
So now how we should manage the COPD? We have to classify COPD according to its severity. So therefore, we classify that normal, moderate, severe, and very severe. Okay. Please, I cannot do the talk because somebody mute your microphone because I cannot talk in such condition. Okay. So now, and when we are classifying the patients, we have to classify according to first forced expiratory volume. You see, in mild condition, the forced expiratory volume in first seconds mild is normal. In second stage, when we have moderate decrease of forced expiratory volume below 70, in stage 3 we have the severe decrease of forced expiratory volume, and stage 4 we have the very decreased forced expiratory volume. Okay, this is usually indicate the highest stress category. In stage 1 we have only given the short-acting beta agonist. Okay. In stage 2, we can give short-acting beta agonist and inhaled steroids here, okay? So we can, or alternatively, we can also give the long-acting beta agonist, but it's better to do the short-acting beta agonist together with inhaled steroids. Stage 3, we have to give short-acting beta agonist, inhaled steroids, and long-acting beta agonists, okay? And stage 4 requires everything same, and we are adding the oral steroids here, okay? And sometimes we can also consider this surgical treatment. For example, we may consider here as a lobectomy. Do you know what is a lobectomy? Huh? Lobectomy when we are surgery and removing the lung lobe, okay, from the lung.
Okay.
This is usually okay. And here, so in order to also we have to do vaccination of patients who have COPD, right? Because here we have to vaccinate patients against the influenza virus. So we have to do also the pneumococcal vaccination, and we have to also do the flu vaccination. Usually in patients who have COPD, we are vaccinating for flu as well as for pneumococcal infection, okay? As well as we have to encourage patients to quit smoking. It's very important to encourage patients to quit the smoking as well. Okay? and to achieve some physical activity. You see, these are considered as main treatment of COPD patients. Okay, clear for you.
Yes, yes.
Do you have any questions?
No. So for our midterms, you don't have any exact date, right?
No, I'm not thinking about this. I will think about this next week. Okay, it's not changed. I don't think about the midterm. Okay, midterm I will be thinking about this next week. Today I have no idea about the midterm. Okay.
Okay, okay.
Okay, now let's make break and afterwards I will talk about infectious diseases. Okay.
Yes.
Okay, let's make 10 minutes break and then I will start about infectious diseases. Okay.
Okay.
Okay, doctor.
Liam?
Margin.
Okay, guys, now let's proceed with gastroenterology. Huh? How do you think? Let's start gastroenterology. Hmm? Are you here, guys? Are you here, guys? Are you listening to me? Hmm? Okay. Okay, let's start. So now let's start about talking about the gastroenterology, okay? And let's start consideration about the esophageal disease. Do you know what is the esophagus? Huh?
Yes.
So, and let's start talk about the esophageal diseases. This includes esophagitis, motor disorder, divertical diseases, and some we have to do the differential diagnosis. So most frequently you will see the GI reflex, gastroesophageal reflex disease. This is called the GRD. What is the gastroesophageal reflux disease? We have the reflux of the gastric acid into the esophagus or in proximal structures, okay? Here, why it's important for the dentist? Because sometimes you may have the caries due to gastroesophageal reflux disease. Why? Because gastric acid, when it reflux into the oral cavity, it may lead to dental damage, and finally, it may lead to caries. Okay. Therefore, we have to know what is the GRD. Clinically, main symptom of the GRD is dysphagia, and but sometimes we may have also the asthma, cough, or dental erosions, hiccups also. So why? Because this acid, which usually from stomach, may lead to damage of the teeth, and finally it may lead to caries formation. Okay. The diagnosis of GRD is made by upper endoscopy and ambulatory pH monitoring. What is the upper endoscopy? The patient should swallow the tube, and in this tube we can see what is happening into the esophagus. Okay. Alternatively, we are also can measure the pH inside the esophagus in order to assess whether there is a state of acidicity or not. Usually in the esophagus we should not have acid, but in case of GRD, as a result of the reflux, we may have the acidicity of the lower part of esophagus. Okay? Clear for you. This is the endoscopy of normal esophagus. And here we have the reflux esophagitis. You see here we have the inflammation, this damage of the esophageal mucosa. You see this one? And this is a consequence of the reflux esophagitis. Do you understand, guys? Clear?
Yeah.
So, which are the main management here? We have to also encourage patients to do some lifestyle modifications. We have to ask patients to take the low portions of the meals, and patients should not take the meal before the sleeping. If you want to take the supper, she should take the supper in 2 to 3 hours before she will go to the bed. Okay? As well as while they are sleeping, they should sleep with elevated head. The head elevation should be around 45 degrees, okay? And these patients should avoid chocolate, coffee, or such type of medications which may exacerbate the GRD, okay? Clear? Medications, we can also use several medications in order to protect the esophagus from the acid, therefore we can use the PPIs or H2 blockers, okay? If we have the dental caries, you know what to do, okay? Clear? Now, other diseases of esophagitis, we may have the esophagitis due to infected diseases like bacterial esophagitis, we may have also viral esophagitis, or we may have also chemical esophagitis, and we may have also the eosinophilic esophagitis. Anyway, we have to assess why the esophagitis was occurred, and finally we have to give here treatment, okay? For example, here we can see the eosinophilic esophagitis here, okay? Here we have the candida esophagi. Do you know what is candida? You should know because you are dentist. Yes, you should know what is candida. What is the candida, guys? Huh?
Fungal infection.
Yes. Usually this fungal infection usually is seen in oral cavity. Yes, most frequently. So, therefore, you will see many patients with candida slash into the oral cavity.